Good morning, this is Dr. Cindy Hayden, and I will be talking to you today about upper extremity amputation. For the upper extremity, there are several different amputation levels. I will start distal. You can have one or more fingers amputated or partially amputated. You can have part of your hand amputated. Your arm may be amputated at the wrist, which is called a disarticulation. You can have a above and below elbow amputation or an elbow or shoulder disarticulation. If the entire forequarter is removed, including the clavicle, it's called a forearm amputation. In an upper extremity, the most important function that's lost is sensory feedback. We use our arms and hands when we talk and gesture. Our arm and hand function is extremely important for everyday participation in occupations. On occasion, an orthopedic surgeon will decide that an arm or hand that has been amputated can be surgically replanted. In this case, the arm or hand is reattached, and the worst hand replant is better than the best prosthetic device, mainly because there is sensory feedback. When an occupational therapist works with a person who has upper extremity amputation, part of the rehabilitation are these factors. You want them to be independent in their self-care. You want them to be able to return to work either using the prosthesis or without a prosthesis. You want them to be able to incorporate a prosthetic device into their body image, which takes oftentimes more than a year. And then there are several stages to the training. One is to work with a person before they're fitted with a prosthetic device, and the second phase is to do various pieces of prosthetic training, including teaching them how to take the prosthetic device off and on. Pre-prosthetic training, or the stage and phase of recovery before the person gets their prosthetic device, involves several factors. One is occupational therapists and nurses teach them how to take care of their wound or the end of their surgical stump. That includes edema control, and the way that edema is handled is that the person will wear stump socks, which is the picture that you see to the right. There's also a way to wrap the stump to help shape the end of it. It needs to be a nice rounded shape at the end. And we also teach them how to take care of any open wounds that remained after the surgery. When someone has an upper extremity amputation, it's important that they maintain their range of motion in the joints that they have left, and to build their muscle strength back up even to greater than normal, and also to do many repetitions of activities and exercises so that they can build up their endurance in using that arm again. We assess what muscles they have left in the residual limb. Some of the prosthetic devices are controlled with the muscle belly contraction. An issue that's often interferes with a person's ability to adapt to an upper extremity or any amputation is phantom sensation or phantom pain. Most people that have an amputation feel some type of sensation. The sensory receptors are still firing to their brain, and so they may describe a itching or a muscle spasm or burning in a body part that they no longer have. Phantom pain is more serious. It can be very debilitating, and often the person suffers greatly from that, and there are other techniques such as mirror therapy that can address phantom limb pain. We want the person to be able to feed themselves, wash their face, shave, put on makeup, either one-handed, or sometimes we'll put a universal cuff on the end of the stump and then insert utensils into that so that they can be as independent as possible, as early as possible after their amputation. And part of the pre-prosthetic training process is to explore the options of prosthetic devices with your client. In this slide, you will see a method of wrapping the end of a stump so that it has a nice uniform shape and decreases the swelling. A person cannot be fitted for their prosthetic device until the swelling subsides and all the surfaces are intact and well-rounded. Generally, a person who has had an upper extremity amputation will use the prosthetic device long term if their prosthetic training begins within 30 days after their initial amputation. Phases and different things that you want to do with someone in terms of their prosthetic training is you want to train them in the names and functions of the different components of the prosthesis. You want to show them different types of terminal devices. There are various hooks and hands. Most of them open using shoulder movement. You want them to learn how to put their prosthetic device on and off, be able to grasp and release different size objects. You want them to be able to move their elbow, shoulder, and in all different ways to control their terminal device. And you want them to be able to pre-position their prosthetic device. For instance, put their wrist in a locked position so that they're able to complete an activity that they wouldn't be able to do otherwise. Other members of the team that work with prosthetic training are, in addition to OTs, PTs, nurses, doctors, and definitely the prosthetist, the person that makes the prosthetic device. Again, the optimum time to have a person fitted for a prosthetic device is within the first 30 days after injury or surgery. The occupational therapist works with the person, teaching them how to take their prosthetic on and off, to be able to do their upper extremity movements with the hook open and closed with their arm in many different functional positions. So you want them to be able to reach across the middle of their body, above their head, behind their back, and positioning for toileting with their prosthetic device on. Once the person masters putting their prosthetic device on and off and opening and closing the terminal device in different positions, then you would teach a person to be able to do functional activities with their prosthetic device. Things like cutting their food, opening jars, tying their shoes, meal preparation, driving, using hand tools, leisure activities. This is best done in a group where other people also have an upper extremity amputation. If you're working in the military, there's often a group of people that all have upper extremity amputations, and it benefits them to work together in a small group. Also, if you've had a client in the past that's willing to come back and talk to the person that you're working with that's newly injured, that's also helpful. A person that lives with a prosthetic device every day has tips and tricks that you may not think of in terms of functional use. Part of prosthetic training is if their amputation was of their dominant arm, we would need to help the person retrain their non-dominant arm to be the dominant arm, and their prosthetic device will become their non-dominant arm, mainly because of the lack of sensory feedback. So it would act as a stabilizer, and their newly trained dominant arm would do more of the fine motor dexterity activities. Something that you need to be very aware of is the posture that the person assumes when they have on a prosthetic device. You don't want one shoulder raised higher than the other, or their trunk twisting, or them assuming unnatural poses that can cause cumulative trauma or repetitive strain disorders down the road. There are many types of different prostheses, so I want to talk to you a little bit about that. A passive prosthetic device is usually a hand with a silicone glove. It has no moving or working parts. It's basically there for cosmetic purposes. A body-powered prosthetic device, which generally runs $3,000 to $5,000, has a shoulder harness and a cable connected to the harness, or the hook or the hand or the elbow, and it uses shoulder movement to control the prosthetic device. An electric prosthesis uses motors to open and close the hand or move the wrist. A myoelectric prosthetic device the muscles contract in the residual limb, and the motor signals that from those muscles activate the motor for the wrist or the hand or the elbow. And it's often the prosthetic of choice if the person is returning to work. It's fairly comfortable, and it is more expensive. So generally, often a person will learn to use a body-powered prosthetic device first, and the myoelectric will be ordered later once they master the body-powered. Myoelectrics are more expensive and they're heavier. Because they are heavier, myoelectric prostheses are best suited for below elbow amputations. And a hybrid prosthetic device can operate the elbow, hand, and at the same time. So if you have an above elbow amputation, a hybrid prosthetic may be the best choice since it can operate the elbow and the hand at the same time. There are also activity-specific prostheses for basketball, fishing, photography, and other activities. So in general, someone with an upper extremity amputation will try a body-powered prosthesis first. It's less costly, it's lighter in weight, it's more durable, has a harness for you to put it on. Some people think the hooks look ugly and they prefer a non-functional hand based on the appearance. This guy in this slide is actually an occupational therapist. He suffered a farming accident when he was 18, and he lost his right arm below the elbow and his left arm above, his right arm above the elbow and his left arm below the elbow. And he has worked for an occupational therapist for many years, and it took him like a year and a half to learn how to use bilateral prosthetic device. But he functions very well in his job and in his family, and he's not limited on anything he can do. The myoelectric prosthesis, as opposed to the body-powered, operates with the surface electrodes, as we mentioned. You need more cognitive ability to operate it, so someone with a head injury may have difficulty operating a myoelectric prosthesis. It requires less body movement, the pinch can be stronger, the hook can be larger, but it is, again, heavier and more expensive, and the stump shape has to stay the same to be able to use it. And if you break it, then you have the expense and the delay of getting it repaired, sending it back to the factory. There are many reasons that someone would fail to wear a prosthetic device, and the main one is that they didn't get fitted for it within the 30-day period after their injury. They may come to rely on one-handed techniques. They may not have enough training by an OT or a prosthetist. It may not be a good fit or good quality. Some people don't like the unnatural texture and look of the prosthetic device, and you can't discount the families and society's reaction to the prosthesis. Some people have a hard time dealing with the emotional reaction of others to their amputation of their prosthetic device. Problems that can occur with the prosthetic device are bone irritation, poor socket fit, skin breakdown, phantom pain, neuroma, which is a nerve at the end of the stump that gets irritated by the prosthetic device, and then people that have cardiac conditions and especially diabetes may not be a good candidate for a prosthetic device. So the factors to consider for prosthetic wear is the client's tolerance to new information. There's a learning curve in terms of being able to use a prosthetic device. Some people are not very gadget tolerant, so they would not be a good candidate for that. Family support, spouse, friends, community is very important. It's important that they don't have a negative reaction to the prosthetic device, and emotional and physical factors are paramount. Thank you.